what do we think about in terms of selection of first-line chemotherapy in patients with advanced gastric cancer? What factors go into our decision to choose the most appropriate regimen? There actually has been increasing consensus in the selection of first-line chemotherapy in treating advanced gastric cancer. Pretty much the global standard now is to combine a fluorinated pyrimidine with a platinum agent. In the West, it's preferentially infusional 5-FU and oxaliplatin, typically on the FOLFOX regimen. The alternative would be to substitute capecitabine for infusional 5-FU with oxaliplatin. Western studies have all favored the use of oxaliplatin in terms of toxicity and particularly in older patients, and also potentially efficacy with a better treatment tolerance and trends towards better response and survival with 5-FU oxaliplatin-based therapy. In Asia, S1 is used, and the combination of S1 and oxaliplatin would be considered standard therapy as well. In terms of triplet regimens, adding the taxane up front, docetaxel plus fluorinated pyrimidine and platinum, really escalates the toxicity of treatment for arguably a marginal benefit. And some randomized trials have addressed this issue to define what is optimal first-line treatment. There was a randomized trial from Germany called FLOT 65, because we have to remember that most of the patients that we treat are in their 60s or 70s. This is a disease of older patients. And in this randomized trial, specifically focusing on patients 65 and older, it was a head-to-head comparison of infusional 5-FU oxaliplatin with or without docetaxel. And although there was a higher response rate with the triplet regimen with docetaxel, the adverse event rate went from the 30% range to above 80%, and there was no improvement in either progression-free or overall survival. So really arguing that a triplet regimen adds toxicity without clear benefit. And to me, the most definitive study comes from Japan. This was published a year or so ago in Lancet Hepatology and Gastroenterology, in which over 700 patients were enrolled on this trial. It was JCOG 1013. And on this randomized trial, over 700 patients with metastatic gastric cancer were randomized to receive S1 cisplatin with or without docetaxel. And this is probably the largest study to address this question. And it was a negative trial. There was no benefit in any endpoint for the addition of a taxane to fluorinated pyrimidine platinum. No difference in response rate, no difference in progression-free and overall survival, no difference in outcome if we looked at histology, intestinal versus diffuse. So to me, that's a fairly definitive study arguing that the vast majority of patients with metastatic gastric cancer should receive two-drug therapy. In the West, it would be preferentially FOLFOX or a modification or capecitabine and oxaliplatin. We would typically reserve the addition of a taxane for younger, fitter patients without medical comorbidities that might be able to tolerate a more intensive regimen, but really in the circumstance where they're more symptomatic, they have a higher disease burden, that we may want to use the more aggressive regimen to get the few percentage point improvement in response. But that would be the exception rather than the rule.